I now invite our first speaker, Dr. Shruti Gohel. She is a consultant medical oncologist and hematologist at Samanvay Hospital, Junagadh, India, to let us know about what's new data at ASCO GI 2026.
Precision-based, patient-centered GI oncology. I'll now highlight the key studies from this meeting, beginning with Horizon GA01. So in this study, we know that the first line HER2 positive advanced GA are treated by TOGA trial, where we use trastuzumab plus chemotherapy. In this particular study, zanidatamab, a biparatropic binding dual HER2 targeted bispecific antibody, was used along with plus minus tislelizumab in combination of chemotherapy was explored. The primary endpoint was PFS, where we can see that there is statistically significant benefit in both the zanidatamab arm, and there is more than 4-month prolongation. Similar benefit was also seen in OS in both the zanidatamab arm, with median OS being 26 months. If we look at the response rates almost double for the triplet arm as compared to the control arm, being 20% versus 11%. And the safety profile was acceptable. So we can conclude that Horizon supports zanidatamab as a new standard in HER2 targeting agents, potentially replacing trastuzumab, as well as the use of tislelizumab in first-line HER2 positive metastatic gastroesophageal adenocarcinoma. Moving to Illustrate trial, it's a phase 2 study where zolbetuximab was explored. So Claudin 18 is being expressed in almost 40% of gastric or GE junction tumors, and zolbetuximab is anti-Claudin 18 monoclonal antibody. Its preclinical synergy with chemotherapy and checkpoint blockade was established in GLOW and SPOTLIGHT studies. So in this particular arm, the regimen which was used was zolbetuximab in combination with modified FOLFOX6 chemotherapy in combination with nivolumab. So first 4 cycles were, all 3 of this were given, and the maintenance was zolbetuximab plus nivolumab plus 5-FU. The primary endpoint was overall the PFS rate, where we can see that median PFS was 14 months, and if the stratification was being done on the basis of Claudin expression, Claudin high showed higher median PFS, and it was 18 months noted in this particular subgroup. Next stratification was being done on the basis of PDL1 CPS expression in Claudin high expression subgroup, where the median PFS was remarkable 23.6 months, which is like almost 2 years. The OS data is still immature, but the trend is clearly favorable for Claudin 18 high population. If we look at the objective response rate, it is again remarkable 68% for Claudin high group, and the responses are generally durable. So we can conclude that the triplet therapy of zolbetuximab plus FOLFOX plus nivolumab represents a promising strategy for patients with Claudin 18 HER2 negative, locally advanced unresectable or metastatic gastric or GE junction adenocarcinoma with PDL1 CPS of more than 1, and this is going to be explored further in phase 3 USERNA study. Moving to Keynote 937 study, in this particular study, adjuvant pembrolizumab was studied for hepatocellular carcinoma patients who had achieved complete radiological response after surgical resection or local ablation, because the risk of recurrence is as high as 40 to 80% after local therapy. So this was a phase 3 study where patients were randomized 1:1 to adjuvant pembrolizumab versus placebo. And the primary endpoint was recurrence-free survival. If we look at the curves, we can see that both the curves are completely overlapping each other, and similar is the case for overall survival curves too. the hazard ratio was nearly 1 and the p-value was clearly negative. We can again see the distant metastasis-free survival curves. They are again completely on top of each other. So this was a negative trial. Moving to the breakwater study. The breakwater study was a phase 3 trial where the role of adding encorafenib and cetuximab to FOLFIRI chemotherapy backbone was explored for BRAF V600E mutant metastatic colorectal cancer patient, which is the case in 10% of the metastatic colorectal cancer patients. So they were randomized to the study arm versus control arm, which was FOLFIRI plus minus bevacizumab. The objective response rate was the primary endpoint, and we can see a statistically significant difference between two. The objective response rate was 64% versus 40%, with odds ratio being 2.7. The overall survival data is still immature, but there is clearly a trend towards improvement. So we can conclude that breakwater regimen supports the option of adding encorafenib and cetuximab to FOLFIRI as a potential new first-line standard of care for patients with BRAF V600E mutant metastatic colorectal cancer patients. Moving to the last study for the discussion, COMMIT study. So it's a phase 3 study where deficient MMR colorectal cancer patients were randomized to atezolizumab monotherapy versus modified FOLFOX6 plus atezolizumab plus bevacizumab in first-line treatment for metastatic colorectal cancer patients. So if we look at the median PFS, there is a clear early separation of curves, and there is statistically significant difference between median progression-free survival, the numbers being 24.5 months versus 5 months. And but there was no difference in overall survival. So we can conclude that the combination of chemotherapy plus atezo plus bev was statistically significant over using atezo monotherapy and in terms of progression-free survival benefit, but there was no overall survival benefit. Thank you so much.
Myself, yeah. So Shruti, thank you very much for an excellent summary of the 5 important data that was presented. As you said, it is very difficult to cover all the topics, but I really thank for the wonderful job that you have done. So can I share my screen, please? Let us start with the panel discussion, and let me welcome all my panelists, Dr. Aparna, Dr. Neena, Dr. Anant, Dr. Bhawna, and thank you all of you for joining us and taking time out, and I really appreciate that. So, unfortunately, Dr. Saltz could not join us, but let us start the panel discussion. So can I share my screen?
Yes.
Yeah. So, are my slides visible?
Yes, sir.
they were
Your
good.
slides are visible.
Yeah. So to start, I have no conflict of interest. This webinar is meant for practicing oncologists to understand data from GI 2036 meeting so that it can help them for better decision-making in patient care. We appreciate efforts taken by all the trialists while planning and conducting clinical trials, and we thank all the patients who participate in those trials. We believe that all trials, be positive or negative, are important in improving care for cancer patients. And in this webinar, we will discuss select important data presented at ASCO GI 2026. So moving on, of course, this is the drug which is the talk of the town when we're talking about ASCO GI 2026, zanidatamab. And it is a bispecific antibody. And as you all know, bispecific antibodies are coming in every solid tumor. So why the GI cancer should be left behind? And they say, at least that was what presented, that it has synergy with the PD-1 immunotherapy drugs. And the trial that was presented was Horizon GA01. And of course, if you see, the trial had three arms. One is Trastuzumab plus chemo, the other was Zani plus chemo, another was Zani plus Tisle plus chemo. There was no the standard of care, the current standard of care arm. So let me start with Dr. Anant. What is your view? Are you happy with the trial design? Or do you think they could have amended the control arm? And another important point, if you see the stratification, there is no stratification for PDL1 more than 1% for less than 1%, even though they have the subsets, but it was not pre-stratified. So what's your thought on this, Dr. Anand? Let's start from you.
Yeah, so in an ideal scenario, I think they could have included an arm which included immuno as well. That's the easy answer to say. But I mean, the driver in this is HER2. So as long as they have a good HER2 addition as a control arm, I think that is fair. They could have amended it later, but I think this is a fair comparison because the quantum of differences seen later probably say that this is an approach to be used. So I think that is okay. PDL1, I think, and the other panelists can chip in, to me is just an iffy marker per se. If we would have to look at it, we would have to look at CPS or TPS at least, and then maybe a stratification may have helped. But I think the way this molecule has performed in this trial, where some cohorts are seeing a survival of, what was it, 26 months?
Yeah.
I think these differences would have remained per se. That's what I feel.
Yeah, so I agree with Dr. Anand. The explanation which was given during when the trial was presented was it started quite early and it is a global trial, so not in all parts of the world. IO was a part of the approved standard of care, so pretty much okay. Now, if you see these things, they have similar the doublet and triplet, the Zani plus the chemo versus the Zani plus Tisle plus chemo. They have more or less similar PFS and overall response rate. But the OS was maximum for the triplet arm. So is it really the effect of Zani or it is the effect of the tail of the curve of the IO? What do you think?
So I think the moment you bring IO into the picture, the tail of the curve is kind of to be expected, right? So I don't know whether we'll find the answer as to what contributed more to those differences in survival, but I think based on our experience and the data with immuno, that would have contributed to these longer survivals. That's what I feel. I don't think we can split it into what was the difference because of either drug or so.
Yeah. So Dr. Aparna, I want to bring your attention that if you see the subgroup analysis study, PDL1 less than 1% actually is doing better as compared to those more than 1%. And you cannot say that the numbers are too small because there are reasonably good numbers in both the apps. So why this paradox? Is there any explanation, or do you think this is just a one-off thing and we should not look too much into the subsets?
Yeah, I mean, I think it's a little bit perplexing. And to your point around the contribution of the tizzy, it's hard, and then to not have the standard of care be the control arm here. I think taking a step back, though, I think you'll get to the toxicity slide next, so we'll take a look at that. I think we just still have to recognize, though, that outside of head-to-head comparisons, taking a step back, it's still a big win for patients. This is the longest OS data that we have seen to date yet in HER2-driven gastric cancer. I, entirely agree that control, we all would have loved to be the standard of care keynote control, but it would have been really nice to have stratification by PDL1 status to at least, outside of these smaller subgroup analysis to get a sense of what the TISI contribution is, especially in the CPS low patients. If we all remember right from keynote, the benefit really was in the 1+ patients for Pembro in the keynote study. So those are some of my concerns here.
Yep. So as you rightly
Particularly
said,
as you
that
put it,
yeah.
toxicity, as you put into perspective the toxicity here, it's not trivial. I think we'll talk about Alestrio next, but giving the Claudin 18.2 in clinic, Zolbi is a tough drug, really remarkable nausea, really patients almost need to be sedated, to
Yes.
tolerate this.
Yes.
And I think with here with Zani manageable, but still not only the infusion reactions that you see, but the diarrhea, as you're seeing here from the AE table, is non-trivial.
So let me ask you, of course, it's not yet approved, but in case it is approved, are you going to change your the current standard of care? So the survey is done by the oncology brothers, and the results is in front of you. So what is your thought? Will you wait for the OS approval, OS data, or if it is approved, you will offer this choice and probably you use it?
I think, in the US, when we, don't have to necessarily consider cost as much, I think we will be using it once we have approval here. I think this will be the new standard of care, but I think waiting for OS, especially given kind of cost and tolerability, especially as we think about kind of non-US coverage patient populations, is entirely reasonable still.
So you will use it for PD-L1 negative also, if it is approved for all.
I will use it for all.
Yeah. So
Yeah,
as we
based on
all
the
say,
data we're seeing now. Yeah.
yeah, so we all say, no, Anant, that we don't have to worry because probably our patients most of the time will not afford it only. But as everyone is rightly saying, this is a major trial. The OS up to 26 months is a significant improvement. And of course, we like to see the final mature OS, but it's a trial which is very well presented, and it's something to look forward to. And let us see whether the US FDA gives approval in near future or not. So now the another important question that comes, Dr. Anant, to begin with you, where does this put trastuzumab deruxtecan? And Destiny Gastric 05, trastuzumab deruxtecan, pembro plus chemo is going to come up. So of course, this is too early to say, but what is your thought process? Do you think this Zani will be better than trastuzumab deruxtecan in this particular setup? An
So
IO plus chemo combination was Zani versus the same with trastuzumab deruxtecan?
yeah, so there's this, I think, what was it? Was it in Batman? Insurmountable force versus something object. We all thought that deruxtecan would probably, you know, I think be the bona fide drug for her too. I think, zanidatamab in both gastric and I think later data with biliary, both are going to be tough to beat. 26 months is a lot. So to me, I'd be really interested. I'm not sure about rivelostomig. I have my reservations on TIGIT inhibitors, except for a few this one. But yes, I would be very interested in TXD plus pembro plus chemo. I would
Bhawna,
be
your thoughts?
interested.
Trastuzumab deruxtecan, do you think this particular new drug bispecific will be better than TDXD?
I think time will tell. We need to wait for the data, but the Zani data looks really promising.
Fine. So moving on, of course, there is another drug, the Claudin 18.2 targeting drug, zolbetuximab. And we have this Illustro trial, and previously we have Spotlight trial, and reasonably good data. Of course, Illustro is quite an early data. So what is your thought on this particular drug? And Dr. Aparna has said that it is quite difficult to manage the drug. The Kohiru Shineta, who presented the drug, tweeted just now that there is a paper published in ESMO just now, ESMO Open, about the number of antiemetic drugs to be used. So it's not that easy drug to give. Of course, in India, we don't have much experience of that. But what's your thought, Anant?
So we are part of the Astra trial for second line for
Okay.
one of this ones, and the antiemetic thing is there. It is an issue, and I'm sure our colleagues in the US would know this much better than us, but it is an issue. So I think when and if I think this drug comes in purely from a tolerance point of view, I think it's going to be an issue. Zolbetuximab, yes. I mean, we're all hopefully end of next year is what they're thinking of bringing it to India. So we would hope that we will be able to gain greater experience. My only question, and this is to the US colleagues, is are there any trends or thought process in bringing down the Claudin cutoff? Is that going to happen? Because it's what is it, 80% or 75% now? And there was some thought that, if you bring down the score to 50%, it still works. So any thoughts on that?
Yeah, I mean, currently, based on approval, the cutoff is the cutoff. But I think as you're saying, and I can't remember in the phase three trial actually what the cutoff is. I'm
It
trying
was a
to
standard
trying
one,
to
the one
pull.
we are currently
Was it the
using. And
standard?
yeah,
Yeah,
I
that's
think
what
it's
I
the same.
thought.
Yeah.
Yeah. So I think, currently I think the like even the local testing is approved based on the current cutoff. So I don't see us necessarily shifting, at least in standard of care, to a different cutoff here.
So moving on, thanks for everybody for your inputs of zolbetuximab. Moving on, there is of course this interesting trial about Neo Summit, the toripalimab data for the gastric chemo plus IO trial. I know the default is the by default standard of care, but cost is an issue in India. Tori probably is launched by an Indian company. Cost is less. Even there's a phase two data, 22 versus 7 months, 0.52 EFS hazard ratio. Dr. Bhawna, will you be tempted if the Durva is not feasible? Considering this is still phase two data.
Yeah, I mean the hazard ratios and the survival looks really, really promising. I would be tempted, but it's a small study. And the other thing about this study is it was done in China,
Correct.
only one, and also no survival data. And it was local review. There was no central review. And we know the pitfalls of local review. So, and standard is FLOT actually, not KPOX. So,
Yeah, yeah, yeah.
or SOX. So I would wait, but yeah, if financial issues are there, I tend to go with low dose Nivo actually.
Okay, okay. And as it was, I think the news has come today that the Supreme Court has allowed for the Indian company to
Yes,
release the generic
Zydus.
Nivo. So
Yeah,
probably the cost will further come down for the Nivo.
yeah, yeah.
So moving on, it's Dr. Nina. Let me get you into this organ preservation of esophageal cancer. Do you offer this option to your patients in your practice, Dr. Nina?
Um, yeah, so good morning, everyone, or at least
Hi.
it's morning where I am. So I think it's a very topical question. I think the short answer is we do offer it selectively, but generally not as sort of a default standard of care strategy for patients who are surgical candidates, and this is for adenocarcinoma only.
So
Just to, go ahead.
yeah, so I had put all the criticism of
Yeah.
the Sano trial that has been discussed in ASCO. So of course, as a prominent radiation oncologist, I want your thoughts on this.
Yeah, so I think I'll go over these points, but I think what the Sano trial tells me is that if a patient gets cross chemoradiation and they do achieve a complete clinical response, then organ preservation options should be discussed at that juncture. Because I think the trial shows, at least to me thus far, that there's no survival difference, and quality of life is better if you don't remove the esophagus. So I think that's a conversation that should be had, particularly for patients who want to avoid esophagectomy, but they have to understand that they're going to need close surveillance, and about half are going to have local recurrence such that they're going to need surgery. I would also mention, some of these issues pointed out here that there are still unanswered questions with regards to how best to define complete response, how intensive surveillance regimen should be, how reproducible the results are. But then also, not mentioned maybe on the slide is that we know since the Sano trial, the treatment landscape for esophagus GJ cancers has changed. And with ESOPEC and Matterhorn, we know that those peri-op systemic IO-based regimens have better survival. And since then, they, I think, really defined the standard of care for patients with adenocarcinoma who are eligible. So I think upfront, that is what I would offer. But, I think at the end, organ preservation is a really highly patient-centered strategy. It has the potential to improve quality of life, as we've seen in rectal cancer. So, what I'd like to see moving forward are trials that really integrate the best systemic and best local therapies. So, we can maximize both local and systemic control. So we're not, there aren't oncologic trade-offs, so-called trade-offs when we're pursuing organ preservation.
So according to you, this is where the field is moving. Dr. Bhawna, your thoughts on this, especially in our setup. What is your
So,
thoughts about the
I
organ
think
preservation?
it's unlike rectal cancer, where, we do watch and wait strategy. And when we do salvage surgery, the morbidity is not as much. But I think here they've shown that about the 30% patients who do recur, the morbidity and the risks associated with salvage surgery are higher. I mean, I will, of course, offer this to patients, but I would love to ask Dr. Neena one question, which we see quite frequently in clinical practice. When we've decided on neoadjuvant intent, the patient's swallowing improves and they have had a good response, and then they decline surgery. So then what do? Do you give more radiotherapy because you've given a lesser dose because you've not treated them with radical intent, or what do you do in your practice?
So you mean they've had chemotherapy?
They've had a cross type, neoadjuvant intent.
So would you add more radiotherapy to? So my standard dose for radiation, so cross goes to 41.4. I generally go a
Yes.
little bit higher to 50 gray, either pre-op or definitively. There's really no, unfortunately, all the trials of dose escalation in esophagus cancer have been negative. So there's really no data to go above, I would say, 54 gray for really esophagus or G junction
But
cancers. But
you do
generally, I
the
go to 50
staging
gray.
scan 6 weeks later, 4 weeks later, and you find out that they've had a complete response, and then they decline surgery, and they've only had 41 point whatever the cross dose is. So would you give them increase the dose and complete to 50 gray, or just
I
leave
don't
them
think
alone
if
and give
in
immunotherapy?
that case, if for some reason I treated a 41.4 gray, which I typically don't do, I don't think if they've had a break already, there makes a lot of sense to add the 10 gray after. Hopefully this would be a case where they had biologically radiosensitive disease. We know in cross that adenocarcinomas had a 23% pathologic complete response. Squames had nearly a 50% complete response. So, perhaps they're in that biologically favorable bucket. So I wouldn't add more.
Yeah. So
Right.
thank you for your inputs. Moving on, Dr. Neena, the critics too was presented here. Of course, now the standard of care has moved on, but this is one of the slides from that discussion that it should not be routinely recommended, the
Yeah.
neoadjuvant CRT in 2026. So what do you think? To which selected patients will offer this, or probably to nobody?
So I like this table. It's comparing Top Gear, which was a phase 3 trial, looking at peri-op chemo without pre-op chemoradiation. That was completely negative. And then Critics was a phase 2 trial, smaller study. So Critics 2 compared 3 neoadjuvant regimens. One was chemotherapy alone with docetaxel, oxaliplatin, and CAPE, which is not the current standard of care anymore, versus radiation alone versus chemotherapy plus radiation. And it showed that 1 year event-free survival was best with both chemotherapy and pre-op chemoradiation. So I think, it being a phase 2 trial, it doesn't define a standard care, and also with the outdated chemotherapy. But your question of when would you consider neoadjuvant chemoradiation in 2026, I think there are still scenarios where it makes sense. I think the first thing, and I like these points. So I think the first thing to emphasize, because I think sometimes it's missed or it's forgotten, is that ESOPEC and Matterhorn were adenocarcinomas, right?
Correct.
Of course, squames are less likely in gastric and distal esophagus, but still, if you have an upper or mid esophagus and it's a squame, then cross is still a standard of care, at least for now. I think if the patient is not a candidate for FLOT or DFLOT, there's trials such as NeoAegis that gives equipoise between cross and ECF. And then third, I think this is a little bit controversial, and I heard different thoughts on this. But I think if a patient is T2N0, right, they're not node positive. And this is sometimes hard to discern based on the staging that we have. But if you really think they're a T2N0, if you look at some of the forest plots in these studies, these peri-op studies, with all the caveats of these subgroup analyses, these patients appear to benefit less from the intensification of systemic therapy because their disease burden tends to be more local. So what's
your thoughts about these indications,
so I
especially
think
to
this is
give
very reasonable.
RT after FLOT IO, FLOT plus IO?
Essentially, the first thing to see here is that it says when to consider. So it's not everyone, it's just when to think about adding pre-op radiation. And I think these all make sense. I mean, essentially, if a patient's had chemotherapy and you're still concerned about a positive margin, right, then it makes sense to add pre-op chemoradiation. And the second one, kind of related to the first one, if they've had a poor response to chemotherapy, then you might think, why am I going to add the same chemotherapy after? Might make sense to pivot to something else. And then the third is kind of what I mentioned, if the patient is not a candidate for intensive chemotherapy. So I think it's something that is not a standard, certainly, and I think that point was made in the discussion, but I think we all agree there are subsets of patients who would probably benefit from the addition of chemo ads.
Dr. Aparna, your thoughts on this as a medical oncologist? Where to put in RT in today's era? DFLOT, everything is available.
Yeah, I mean, I think I really like this slide and agree with Nina here. I think for the majority of patients, we're using DFLOT as our new standard of care over the last year. So I think these are very appropriate case by case discussions to be discussed with patients. I will say, I was wondering, Nina, I'm not sure what you're doing at your institution, and I'm in India as well. Are you guys doing for patients with node positive disease? Are you doing laparoscopies at diagnosis or?
Yeah. I think we do a lot of staging labs.
Yeah.
So,
bulky tumors, node positive.
Thank you. Thanks for the inputs. Moving on. Of course, this is something that Nina, you tweeted. This is the upcoming trial you're excited about, the FLOT plus Pembro plus local RT. She's very happy to see this. So, so this is something which has been presented as the upcoming trial, and probably this will answer us a few questions to add the local RT to the FLOT plus Pembro. Of course, not FLOT plus Durva, but this is something to look forward to. Now, moving on. Of course, now let's move to the HCC. And Dr. Bhawna, you are probably treating HCCs for many, many years, 30 years, and probably this is the only solid tumor where nothing in the adjuvant works, neither the chemo, nor any targeted therapy, nor the IO. We have this adjuvant Pembro trial, and it's negative, and this is a list of all adjuvant IO trials, Atezo plus Bev, Pembro, Durva plus Bev. Most of them are negative. So why is it like that? Why is such a tough cancer to treat?
And also the trials, post-TACE, TARE, post-local regional therapy with Lenva, sorafenib, they've all been negative. I think, I'm just speculating here that the whole point of adjuvant therapy, systemic therapy, is to address the micrometastasis. And that is not how HCC recurs. And I'd love to hear what others think. This is just my theory. I think that either you have recurrences which happen within a few years, which is the local tumor seed, or they happen a couple of years later when it's usually a new cancer. That's what they say. And I think because it's not the micrometastasis, so what are you addressing? So I don't think this space we are going to see much results. And plus there is cirrhosis, and most drugs are broken down in the liver, and the liver is involved. And I don't know whether it affects the efficacy or not. So I think all of these could be
the
reason.
So Dr. Aparna, amongst all these negative trials, we have one, again, China-based trial conducted only in China, perioperative IO, but it is showing at least the initial results which are positive. So Dr. Aparna, Dr. Anant, your thoughts on this? Is this the perioperative IO the way forward in HCC? What do you think?
I think, we'll have to wait for more data, but I think to Bhavna's point, I think what we have seen, I think you'll probably need the tumor intact to get any of your IO benefit. We obviously saw that with, first-line metastatic disease. I think as Bhavna was alluding to, I think the liver immune microenvironment in the setting of microscopic disease and how CPIs work, there's a mismatch there. So I think, I think going forward, we'll be looking at combinations, with the tumor intact, with local therapies as well. But agree that we're not going to see probably any role for adjuvant.
Anant, your thoughts on this particular trial?
Yeah, so I think you've put the point there, prior RFA. I think that's something most people don't do, when thinking of resectable HCC. The other thing, probably the only adjuvant therapy that has really worked is the Southeast Asian data on adjuvant HAIC. They have a lot of good data on that, but none of us are really doing that. But I agree with the others that I don't think adjuvant immuno probably is going to help out too much, barring something really surprising in the next 1 or 2 years.
Okay. So, Dr. Nina, whenever we talk about the local therapy for the intermediate stage or an early stage for bridging therapy, everything, it's all about TACE. What
Yeah.
about the SBRT, TAR, or the combination? What's your thoughts on that?
Yeah. So, another really good question. So I think just backing up a little bit, I think the challenge here is that for intermediate stage ACC, it's probably the most heterogeneous group with regards to the presentations, but it actually represents a smaller proportion than either earlier or advanced stage. So it's really hard to come up with like one algorithm for intermediate stage because in practice, these patients could be downstage to a transplant or resection, or if they have more diffuse disease, they could get systemic therapy. So like you mentioned, everything is TACE as with regards to the local regional therapy that's recommended, such as in the Barcelona guidelines. And that's because I think globally, TACE remains used widely. And then in this table you have, all these trials are based on TACE. So that's what the level 1 evidence has, including this ABC HCC trial that's presented at GI ASCO this year. However, I think, hey, girls, shh. All right, sorry. But we know that globally, at our institution and other places, we use a lot more Y90 and SBRT as compared to TACE. So, I think the question is, how do we extrapolate this data or not that's TACE-based to Y90 and SBRT? And my thing is this, generally, I think of Y90 and SBRT as having better local control rates and less toxicity than TACE. So I think if a tumor is amenable to SBRT or Y90, that's intermediate stage that historically you would have done TACE for, then I think it's certainly reasonable to extrapolate that to Y90 or SBRT in terms of local control and toxicity. I think when we think about these trials that are TACE and IO combinations, right, how do we extrapolate that to other local therapies? It's a little bit more complicated. I think I would expect a similar direction of benefit, possibly even a greater magnitude if you're exchanging it for SBRT or Y90. But I don't think we know for sure. And I think that's where, we need the trials.
So, Dr. Bhawna, do you think it's because of these trials, which are the radiation-based SBRT or TARE-based, are difficult to do, difficult to recruit patients? So that is why we have less data. As Dr. Nina says, the TACE is the most globally done therapy. So, what are your thought process on this?
I think for our country, the most cost effective is SBRT. I mean, especially if you have the expertise. I mean, if a patient is eligible for SBRT, at least here, I do not have to send them to a higher center like Tata. And TARE, of course, you have these criteria with portal vein thrombosis. And the other thing is, I don't know whether, Dr. Nina, you practice portal vein radiotherapy. So,
Yeah. So I think there is data on treating SBRT, these tumors with macrovascular invasion or portal vein tumor thrombus.
Yeah.
And then, it becomes eligible for TACE down the line or transplant as well. So sometimes you use it as bridge therapy as well, either TACE or TARE for transplants. So my preference is SBRT if patient is eligible, because we can do it locally.
So regarding this trial, of course, there is ABC-HCC trial, TACE versus atezolizumab. It's an ongoing trial, and they showed the time to failure of treatment strategies better with atezolizumab, but again, it's not an established clinical endpoint. OS is still not yet there. So the conclusion was, of course, TACE still remains an important standard of care option. But Dr. Nina, this is your slide. You have an excellent session in ASCO GI 2026. And you talked about the local therapies in HCC. So what is your take-home message that where you think the local therapy plays an important part? And amongst the local therapies, suppose the expertise are available, which one you will prefer?
So this was for one of the sessions we did sort of like an HCC multidisciplinary tumor board and went through a few cases that we thought illustrated sort of different teaching points. And one of the main teaching points that you had mentioned was basically the role of local therapies, even in patients who ultimately are going to have systemic progression and ultimately need more systemic therapy and ultimately die of their disease. But in many of the cases, these local therapies were able to keep their disease under control with minimal toxicity and used in several settings like pre-post transplant and oligometastatic disease. So yeah, that was the first point. We had basically cases where we discussed sort of what to think about with regards to systemic therapy in the post-transplant setting. Obviously, immunotherapy is not an option. And one of the patients ended up having a lot of toxicity. We mentioned portal vein tumor thrombus. So there was a case where a patient got neoadjuvant Y90 and then went to resection. But ultimately, that patient ended up having sort of rapid progression, sort of illustrating the aggressive biology with PVTT. Another point here is that in several of the cases, patients were NAD on scans, but their AFP started to rise. So a question that came up was, what do you do if you see a tumor marker that's rising, but nothing on scans? And there was a little bit differences in practices, but I think at this point, we're not making treatment decisions based on AFP. And then the last point, which I think was super important, was that, in our panel, we had myself, someone from Stanford, someone from Chicago, but then also a medical oncologist from Italy and a hepatologist from Spain. So really an international panel. We should have someone from India next time on it as well. But really illustrating sort of the global variation in care and sort of many different pathways to approach different cases. So those were the main.
Thank you. There was an excellent discussion. I think those who have access through the whole recording and should go through that. So moving on, there was another point which was discussed in this ASCO GI, that is for Child's B, which most of these patients are not part of the trials. So what is your take home, the therapy that we like to use? And this is a very nice slide to show that the percentage of Child B patients in the prominent trials and their outcomes. So, Dr. Anant, when you have, unfortunately, a patient with Child B or advanced HCC, how you go about it?
Yeah.
You still go for IO-based therapy or TKI, or how you go about it?
So we actually have a trial running for these patients with patients who have liver-limited disease but Child B. And portal vein thrombosis, we are looking at SBRT plus atezo-bev. It's a phase 2 trial that we are running. So we are trying to get as many there. That's one. Second thing is that I explain to all my patients that we'll give you the standard IO, but your expectations in terms of outcomes are going to be less. That's been seen throughout. And in my head, I use a cutoff of B7. Beyond that, I usually don't treat unless they are optimized to less than equal to B7 because we know that Child-Pugh B also is a heterogeneous cohort. Some variables are more important than others, but B7 is my upper limit, and then I give them standard of care explaining lesser expectations. Beyond that, I generally hope for optimization 2 less than equal to 7 and then take it from there.
Dr. Aparna, your thoughts? B7 or Dr. Bhawna, you can put in.
Yeah, I exactly echo Dr. Anant's this thing. It's again, what is driving it? If it's very low albumin, ascites, so B7, if it's towards 9, my threshold to give or treat them, and of course, a good PS is very important here as well.
So it varies from patient to patient and
Yes.
what exactly is the cause of the deterioration. But overall, the take-home message is that probably giving IO here for anything above B7 is risky. And as you see on the right-hand side, the median PFS and OS are not that great. And one should be very careful in treating this patient. One needs to be very selective. So now moving on, we have, of course, the breakwater. The study was published last year in which they have given the combination of EC plus modified FOLFOX6 for BRAF mutated colorectal cancers. Now they have this subset of those who received FOLFIRI. Anant, what's your take? So suppose the access is not an issue and you have all the drugs available. You choose FOLFOX as the chemo partner or FOLFIRI? with EC?
I think I'm okay with both. I think there is more data for one versus the other, but I don't know if that would make a difference in terms of outcomes. I'd love to hear what the others say. I think the outcomes would be similar, is what I think.
Dr. Aparna, what's your thoughts? Folfox,
Yeah, I thought
Folfiri,
that
or as per this
I think
data,
this
you go
was
for Folfiri plus EC?
Yeah, no, I think this was a great, this is great to have this data now. I think many patients have, adjuvant Folfox as well, are already having lingering neuropathy from their prior lines of therapy. And so to see that, I think we are comfortable that you have, equipoise now with FOLFIRI, very, very reasonable. I think in the, US, if you look at community data, real world practices show about 80% of patients in the first line actually get Folfox. But if you go to academic institutions, just to really spare that neuropathy early, you'll see more FOLFIRI use. And, younger women, for example, may not want to lose their hair. So really individualized patient discussion. But I think I think the take home point, and we're seeing this problem even in the US still, is still people are not understanding the importance of first line use. And so as you're getting your biomarker testing back, if you've started FOLFIRI, if you've started FOLFOX, and you get a BRAF V600E, add the Encoraf and cetuximab in the first line setting. I think if people remember, from the Beacon colorectal cancer data, the median OS with the doublet was, around 8.4 to 9.3 months. And if you look here in the first line setting with the chemo combination, we're talking about 30-month overall survival here in the first line setting. So whether it's FOLFOX or FOLFIRI, I don't care anymore now seeing this data. But if you get V600E back, please do just add the targeted therapy in the first line. It matters.
Yeah. So I asked because we are somehow intuitively tuned to start Folfox first and then give Folfiri on the recurrence. And this is probably telling you to do the other way around. And as you rightly said, probably doesn't matter as long as we are able to have EC and partner with either Folfox or Folfiri. So thanks for those inputs. And moving on, now this is the something which is very interesting, the Comet trial. And I would like to have a look at the left side curve where the single agent atezo unfortunately significantly underperformed. And there's a lot of discussion about, of course, about this particular trial as well as the implication on the adjuvant data. So let me ask that, Aparna, why do you think that, first of all, do you agree that atezo underperformed in this trial? And
Oh,
if yes, why?
it's terrible. Really, really, really dismal, actually. And I've been really actually trying to wonder a little bit around why in the interim analysis, like, did they know that it was performing this badly? And kind of a little bit curious to really understand why the trial was led to actually continue. They obviously stopped once we had kind of ipi-nivo first line approval data, but it's troubling to me, especially in line of atomic. I think we were all struggling a little bit what to do with atomic anyway in this era of niche, and we thought that we had good data to give, at least if you were node positive and didn't get neoadjuvant therapy. And so this is giving me some pause too. So just to take a step back for patients who may be clinically stage 3, recognizing how challenging it is to stage colon cancer patients that are MSI high. We have at least been having a discussion around neoadjuvant niche, 1 dose of ipi, 2 doses of nivo, more and more for younger patients. Or for older, but little old ladies, MSI high, which we see a lot of, might do 6 months of monotherapy. But had you been, stage 3, not given neoadjuvant therapy, again, outside of cross-trial comparisons, it's hard to ignore the niche 100% 3-year DFS. And, in atomic, you still saw close to that, 85% range, but it's not 100%. You're subjecting patients to chemotherapy It was a year of atezolizumab. And so, what I had been doing for many of my patients is having that discussion of, do you really want, we know that chemotherapy is not likely to be as effective. So do you really want to do chemo IO? Or maybe we check ctDNA, and then at the time of ctDNA positivity, we give atezo, right? But now again, seeing this, it's giving me pause to whether we should just be doing PD1. That being said, the way I frame it for patients when you see the 8HW data is that, very likely we don't necessarily know in the salvage setting, for patients that were recurrent after in a stage 3 disease, but at least in the first NL line setting, patients do very well with ipi-nivo still curing these patients. So it makes it tricky. Maybe it is a PDL1, true PDL1 versus PD1 impact, and I think we're all kind of scratching our heads here of, we didn't think PDL1 was going to be that bad.
Yeah,
But
because if
welcome
you
other
see,
people's thoughts as well.
yeah, if you see the non-small cell lung cancer, it's metastatic setting, it doesn't make a difference whether it's PD1 or PDL1. But suddenly in an MSI high colorectal cancer, we are seeing that unfortunately atezo is underperforming drastically. So we don't know probably the reasons that why in a particular tumor type there is a difference and in other tumor type there is no difference. But overall, we need to be skeptical. But let me ask you another counter question: that suppose it's the metastatic colorectal with an MSI high, do you go for double I or single I?
Double.
EP-Nivo or pembro?
Hands down, double.
Oh, oh. Anant?
Yeah, hands down at Nivo.
And we are not worried about the
Of
initial
course,
toxicity.
it's the toxicity was actually not that bad from 8HW. Of course, patients that have underlying, bad autoimmune conditions, there are certain patient populations you may not, but for the far majority of patients, giving doublet.
Yeah. Anant, your thoughts? And Dr. Bhawna, your thoughts on this? The doublet was a single agent for a metastatic colorectal MSI high.
I think the key thing pushing at least me towards a doublet is the initial curves, with monotherapy, there was those initial high numbers of of progression. That's not seen with the double immuno, so I would definitely consider that, assuming there were no other constraints, no doubt.
Fine, fine. So thank you. So now we have, of course, some audience questions, and a lot of people have asked the question to this. So Dr. Nina, I want to ask your opinion. For a locally advanced or borderline resectable, not locally advanced, borderline resectable pancreatic cancer, any role of neoadjuvant CTRT or it's neoadjuvant chemo alone?
Yes, very good question. So yeah, there was a really good session also on borderline locally advanced pancreas cancers, but borderline is really for us a case-by-case basis. For all these patients, we definitely start with chemotherapy, usually either FOLFIRINOX or gemabraxane, and then we'll reassess. And basically, if after chemotherapy they are persistently borderline, particularly with, and we take into consideration arterial more than venous involvement. So, like if there's still concern for resection issues at the arterial interface with the tumor, then we'll add preoperative radiation. So it's basically like if they're initially borderline, they start with chemotherapy, and if they're persistently borderline after chemotherapy, particularly with arterial involvement, then we do add preoperative radiation, and we tend to favor SBRT.
And how's your response? How's the results, at least in your center? Do you think it works?
I do think it works. I think we need, hopefully. So, there is the PREOPANC 2 trial, which basically looked at borderline and resectable, but the results were, basically for borderline and resectable, that compared preoperative radiation to FOLFIRINOX, and it actually showed no difference between the two. So if you look at that trial alone, then I think there is equipoise between the two regimens. Of course, there are caveats with that study. And then PREOPANC 1 showed a benefit to preoperative radiation versus gemcitabine. Obviously, there's caveats with using gemcitabine as a comparison. So I think for it's not going to be all borderline patients. So that's sort of the challenge, is that if you take all patients who are borderline resectable at diagnosis, not all of them are going to need preoperative radiation. But if you are concerned about getting an R1 resection, then I think that pre-op radiation can help.
Yeah. And now another common question that I want to ask is, what are those patients in which for rectal cancer, and you definitely do not offer them the total neoadjuvant therapy or wait and watch? To patients to whom you will not offer the TNT or wait and watch. Dr. Nina, Dr. Aparna, your thoughts on this? Because a lot of enthusiasm in our part of the world about the TNT and wait and watch approach. So what are those patients in which for sure you will not offer this? This is one of the questions that has been put. So Dr.
I
Aparna, you
guess,
want to take this?
I guess everyone we offer total neoadjuvant therapy to, right? But in terms of the sequencing and the goals of care being non-operative management up front, I think we have a very careful discussion. I think there was a really nice, 1 or 2 years ago at ASCO GI, a really nice discussion by, one of the radiation oncologists in the Northeast. And keep in mind that right now, Prodige is the only trial where we have kind of 7 and even now 10-year survival data for higher risk patient populations. So in a younger patient population, T4 and 2, when your risk of distant recurrence you think is high, even if it is a lower lying rectal cancer tumor, I will have that discussion of offering chemotherapy first rather than chemo RT first. And again, we understand that the non-operative rates will be lower with that approach. But if they do get a clinical complete response in that setting, we will have that discussion with the patients. But my practice is bias. I see a lot of younger patients as well. And we know that in rectal cancer, unlike colon cancer, you do get those distant recurrences, and that 7 and 10-year data matters to me when I'm talking with patients in terms of survival. So we do use a lot of non-operative management, but you do really want to think carefully about which are the patients that you might want to start with systemic therapy for. Janice has completed, right? So Janice is looking at chemo RT first and then triplet versus doublet. And so it's not going to necessarily answer the question of chemo versus doublet randomized prior to RT for survival, but at least will give us the answer of does triplet therapy for select patients not only improve your downstaging after chemo RT, but more importantly, I think is cure and not limiting that cure for patients. So Nina, I'm not sure if you have any comments there, but that's how I think about it.
So Dr.
Yeah,
Nina, your thoughts on this?
yeah,
Her practice is predominantly younger patients. So what about, say, elderly patients? Which of the patients do you offer TNT to all? What is the sequence that you use? And do you offer organ preservation to everybody in your practice? How you go about it?
Yeah, so I agree with everything Aparna said. Yeah, so I think first of all, the patient has to be someone that you think is going to follow closely in surveillance, because the watch and wait follow-up protocol, at least for the first 2 or 3 years, is pretty involved. So they have to be committed to doing that. You don't want to just lose them. And I think there is, I think all things being considered, if you can keep your rectum, that's great, obviously. But I think there are different trade-offs if you need an APR versus an LAR. So I think the impetus for organ preservation is higher in patients who need a permanent colostomy. I think we sometimes don't do the TNT strategy for all up front if it's sort of like a not super locally advanced case where we think that they may not need all that upfront chemotherapy, and the toxicity could potentially be less with upfront surgery without giving everything neoadjuvant. And then, yeah, so I think maybe we are a little bit more selective. And then the other point, it's sequencing chemo versus chemoradiation. Completely agree with Aparna that if, we're really worried about distant spread, then like high nodal burden, EMBI, their tumor markers really high, then we do tend to do chemotherapy first. And sometimes those patients have really big and ugly tumors that, their likelihood of achieving a complete response is probably going to be very low. Like you look at it and you're like, maybe they're really going to be biologically sensitive, but you're probably not going to get a complete response. So, I don't think we're really pushing organ preservation as something that's going to happen with a high chance. And then definitely in those cases, we'll do chemotherapy first.
So Dr. Bhawna and Dr. Anant, just before we close, what's your thoughts about this in Indian setup?
So my preference is chemo as well first, especially if they have EMBI. And, they respond so beautifully. They come with a tube, not being able to sit. And usually after one cycle, most of them, FOLFOX I usually start with and then move on to FOLFIRINOX if they can tolerate, followed by CTRT. But some patients, we may go for CTRT first. It depends on their funding, etc. as well.
Anant, your
Yeah.
final thoughts?
So going back to your question, where will you not use TNT? I think the prospect kind of patients are probably the best ones not to use TNT.
Yeah, that's
I think we should not largely do TNT in them. The rest completely agree with what everyone said. And the low rectal tumors, I think that's where, we go all in with TNT and the others maybe not so much. We've just got a study approved for the Rapido versus Prodigy approach. It's phase 3, large. I don't know. It'll take us 5 years, maybe some answers 5 to 7 years from now.
Fantastic. So
well
thank you,
done. Great.
all my faculty and all the people who have joined. Thanks, Dr. Aparna, Dr. Neena, you're taking time from your busy schedule. Thanks, Dr. Anand, Dr. Bhawna, Dr. Shruti. Thank you for the wonderful presentation. So I really appreciate your time and efforts into this academic activity in the beginning of 2026. Hopefully, we'll have many more in the future. So I end this with thanks once again to everybody and wish you a happy and prosperous and healthy and academically prosperous 2026. And hopefully, all your trials recruit patients faster, Neena, and hopefully, we will meet in person this year at least.
Oh, thank you,
Thank you.
Amol. Thank you so much.
Thank you, everyone.
Thanks, Dr.
Thank
Aparna.
you.
Thanks, everybody.
Thanks,
Bye-bye.
everyone.
Thank you.
Bye-bye.
Bye. Bye. Thank you.
Thank
Thanks.
you so much.
Thank you.